Good morning, ladies and gentlemen. It's a pleasure and a privilege to be here. Thank you very much for your kind words of introduction, and I'd like to thank Dr. Unnikrishnan for inviting me here to this prestigious conference, where I will be speaking about rewinding the journey of CVOTs with GLP1RA. So basically, my job here is to tell you what has been happening in the CVOT journey as far as GLP1RA are concerned. But to do that, let me introduce the topic by telling you what GLP1RA does to the cardiovascular system. Now, we know for a fact that there are certain risk factors for cardiovascular disease associated with diabetes, of which poor glycemia and weight gain, we all know are associated with worsening cardiovascular outcomes, and these are addressed very well by GLP-1 receptor analogs. I think all of us are in agreement about this, but let us look at some of the other risk factors that GLP-1RA addresses, and this is systolic blood pressure. And across the board, if you look at all the phase 2, phase 3 trials with GLP-1RA, you see that there is a statistically significant reduction of systolic blood pressure with GLP-1RA. But this comes at a cost, which is a rise of heart rate. This is seen with all the GLP-1RA, including exenatide, once daily and once weekly, liraglutide, as well as alpiglutide and dulaglutide. Now, of course, we get concerned that there is an increase in heart rate and whether this should be a risk factor for heart disease. But that is usually when you have an increase in heart rate of more than 10 beats per minute. And as you can see very clearly from this slide, that only about 1 to 4 beats per minute is increased with any of the GLP-1RA, which means that this increase in heart rate is not an increased risk for any kind of cardiovascular disease. We come to the lipids, and as you can see in all this is the liraglutide trials, we see that there is a reduction of LDL cholesterol, total cholesterol, and triglycerides with all GLP-1 receptor analogs, and as you can see, quite interestingly, we find a rise in total cholesterol and LDL cholesterol with rosiglitazone, which has been associated with an increased risk of myocardial infarction. In fact, if you look at what happens to the postprandial triglycerides and the ApoB48, you see a statistically significant reduction of these toxic cardiolipid molecules in patients who are taking GLP-1 receptor analogs. So this is another area where GLP-1RAs work on the cardiovascular system, reducing blood sugar, body weight, systolic blood pressure, and cholesterol. So it is not surprising that when we first did a meta-analysis of the MACE of all the GLP-1RA trials, we found that when you compared it with active comparators, the diamond was just in the middle, which showed that there was a complete safety of these molecules. But when you compared it with placebo, you found that there was a statistically significant improvement in cardiovascular outcomes as far as GLP-1 receptor analogs are concerned. This is one of the most quoted papers by Monami, which was published a few years ago. And this kind of set the ball rolling to show us that GLP-1RA are good drugs for the heart over any other competitor drug that you might have. But that is not all. Diabetes and the heart and the CVOT, all these things are very closely interlinked. We know CV outcomes are worse in diabetes. As you can see, diabetes in itself leads to 6 years of loss of life if you take the average life expectancy of 60. And indeed, if you have myocardial infarction or stroke associated with it, this leads to a loss of life of about 12 years. Now, till a very recent past, say about 15 years back, drugs were used to reduce blood sugar, and that was it. There was no other further thing. But then came the famous Nissen paper, which showed that rosiglitazone increases the risk of myocardial infarction and all-cause mortality in patients with diabetes who were taking the rosiglitazone. The FDA therefore mandated at that point of time that any new anti-diabetic drug which comes into the market must have a dedicated cardiovascular outcome trial to prove that it does not cause any cardiac harm. In fact, some of the studies were designed to try and show if that would provide any kind of cardiac benefit. And this has been the timeline, and we have seen the results of all these trials come out, whether it be the gliptins, whether it be the SGLT2 inhibitors, whether it be the GLP1RA. Today's discussion is about cardiovascular outcome trials with GLP1RA, and I will be rewinding to see what has been happening with all the cardiac trials that have come out. The first trial, which was published with lixisenatide, which is a twice daily used GLP-1 receptor analog, quite a weak drug, and in terms of blood sugar reduction as well as reduction of body weight. And these drugs were tried out compared to placebo, and as you can see, there was no benefit, but there was no harm when you used lixisenatide in cardiovascular outcome trials. Indeed, to look at it in a little bit more of detail, there was about 6,000 patients who were followed up for 4 years, and MACE, which is a combination of cardiovascular death, time to non-fatal myocardial infarction, and time to non-fatal stroke. All these parameters, as you can see, were strictly at the point of unity. There was a slight increase in stroke and unstable angina, but these were not statistically significant. So the first results that came from GLP-1RA was that they're cardioneutral. They do not cause any harm. And thereafter, we've had more trials, but since we're talking about drugs which have been derived from the exendin backbone, I thought it would be prudent for you to know about what we found in the EXCEL trial, which is with exenatide once weekly, which was again used in a cardiovascular outcome trial to see what happens with exenatide. Now, why have I clubbed these two drugs together? Because both of these drugs are from the exendin backbone of GLP-1 receptor analogs. And as you can see out here also, there was no difference across the board, whether you look at MACE, whether you look at death from any cause, death from cardiovascular cause, nothing. But there was a statistically non-significant 29% increase in fatal myocardial infarction. And I would not put too much of thought into this because, as you can see, the numbers were very small, just 17 and 13 patients. So do not worry too much about this, but keep in mind that exenatide once weekly did not show the kind of benefit that we had expected from a once weekly molecule. Now we come to the other group of molecules, the GLP-1 receptor agonists, which are descended from the GLP-1 backbone. And herein, the first trial to be published was with the liraglutide, which showed a statistically significant reduction of MACE, and this was driven by reduction of cardiovascular death. Now, I always quote my friend J.J. Mukherjee, who's seated in the first row, that, death is a diagnosis that you cannot mistake. And death is something you cannot fudge. A reduction of death with an anti-diabetic molecule for the first time made us diabetologists put our collars up and say to the cardiologists that we are looking you straight in the eye. We now have a drug which reduces death. And this was a very important finding that came out of the LEADER trial. This not only led to a reduction of the cardiovascular death, but also the all-cause mortality was reduced with the drug which was used compared to placebo. So this is when the first interest started coming out as far as the GLP-1 receptor analogs are concerned. And this was reinstated and reiterated by the publication of SUSTAIN 6, which was with semaglutide. And again, this showed a reduction of MACE, which was now driven by a reduction of non-fatal stroke. So we now had a drug which is not only reducing death, this group of drugs is now reducing cardiovascular outcomes. And we waited with bated breath for a drug result of a drug which had been withdrawn, albiglutide. And lo and behold, when it was published, there was a statistically significant reduction of MACE, and this time the entire thing was driven by a reduction of fatal or non-fatal MI. So we have three drugs descending from the GLP-1RA backbone. All three are GLP-1 receptor agonists, and they've had dedicated cardiovascular outcome trials, and all these things have shown a reduction of MACE, and one of them has been driven by a reduction of death, one by a reduction of non-fatal MI, one by a reduction of non-fatal stroke. The entire gamut. So we thought it was prudent to meta-analyze the effects of these modern molecules on cardiovascular death, myocardial infarction, stroke, and hospitalization for heart failure. And as you can see, this is a meta-analysis which has been published recently. There was a reduction in CV death. There was no change in hospitalization for heart failure. But MI and stroke, a composite of MI and stroke, was reduced in the group which used GLP-1 receptor analogs. And why is this important? Because if you look at the global registration of cardiovascular deaths, 85% of cardiovascular deaths are due to a combination of MI and stroke. This is a Lancet paper from 2017, which has encapsulated that we have to look at a composite of MI and stroke when we are addressing cardiovascular disease. And this is what was addressed in the meta-analysis, showing in confirmatory terms that there is not only a reduction in death, but also a combo of MI and stroke, the entire cardiovascular gamut, which we have to treat in patients with diabetes. The meta-analysis showed a significant reduction of total stroke. And indeed, if you take out the lixisenatide from the data, you will see that there is a reduction in cardiovascular death, MI, stroke, and a combination of the two. There is no benefit in GLP1RA with heart failure. Animal studies and small clinical studies have highlighted that GLP1RA reduce inflammation in the vascular endothelial, thereby improving endothelial function in addition to causing vasodilatation, improving platelet stability, also improving blood flow and reducing the platelet aggregation. This has been seen in many non-clinical studies. And since we are seeing the benefits from the GLP-1 receptor agonists, which are descending from the GLP-1 receptor agonist backbone, it seems that it is more prudent to be using drugs which are descended from the GLP-1 receptor agonist backbone than those which have descended from the exendin backbone. Not surprisingly, therefore, when the ADA and ESD came out with their algorithm recently, they put GLP-1RA with proven CVT benefit in the situation where ASCVD predominates. And there was no doubt about it. There was plenty of data. Now we have meta-analysis data that, these group of drugs are the first-line drugs when it comes to people with established cardiovascular disease, because not only does it have its effects on the metabolic parameters, on systolic blood pressure, on lipids, all these translates into a reduction of all the major cardiovascular outcomes. In this setting, the new drug that came into the market a few years back was dulaglutide. And dulaglutide comes with the advantage that it is once weekly. And why do I mention dulaglutide? Because there is something that links this with the topic, and I will come to that in a minute. So dulaglutide was the drug which was once weekly, which came in, and across the board, you see it's superior to pioglitazone, metformin sulfonylurea, superior to as monotherapy, superior to insulin, superior to sitagliptin, superior to glargine, but it lost out to liraglutide 1.8 milligram, a dose which we don't tend to use much in India. However, if you look at the weight reduction parameters, there was a statistically significant reduction, whether you compared with metformin, liraglutide, exenatide, glargine as expected. And indeed, in combination with SGLT2 inhibitor, the SGLT2 inhibitor and GLP-1 receptor analog combination starting to come out as probably the best treatment available for diabetes, there was a significant 4 kilogram weight loss. So across the board, there was weight loss. And if you look at the composite of HbA1c reduction of hypoglycemia and weight loss, you see dulaglutide wins in comparison to all other comparators, showing a statistically significant benefit across all these parameters. And of course, you would wonder whether all this magic is just short-lived. And you have data now comparing it over a 2-year period, showing that dulaglutide is perfectly well maintained and is durable over a long-term period of time. Now, why did I bring in dulaglutide? Because there has been news of the publication of the trial Rewind, which is the basis of my talk, Rewinding the Story with GLP-1 Analogs. The Rewind trial has brought a lot of interest in the field of diabetes and heart disease. We do not know the details, but let me show you what has happened. These CVOT trials, you can see the deep orange is basically people who've had established cardiovascular disease, and the lighter orange is people who've had no established cardiovascular disease. Most of the studies have looked at a majority of people with established cardiovascular disease, except for DECLARE and for REWIND. Now, we know the results of DECLARE, and it's beyond the premise of this seminar to be discussing the results of DECLARE. But what is interesting about the publication of REWIND, which has basically come out with just the top-line results, and this has looked at primary prevention. This has looked at people with no established cardiovascular disease. This has looked at people who are our ballpark garden variety diabetes patient who come to see us. And in these patients, dulaglutide has shown superiority in reduction of MACE. So we look with very strong interest to the publication of the dulaglutide data, which is going to be in the near ADA, which is coming up. And this will probably make a paradigm change in the way we use GLP-1 receptor analogs in the management of diabetes. Now, coming back to summarize, this is the ADA-EASD algorithm, and we know GLP-1RAs take first place when it comes to atherosclerotic cardiovascular disease. It is a very good drug for the reduction of HbA1c without hypoglycemia. It is wonderful for weight loss. So we all know about these things. But till now, the usage of GLP-1RA has been restricted in only 25% of the population with atherosclerotic cardiovascular disease, for the simple reason in the other areas we did not have evidence to use this drug. It does not protect from cardiovascular disease. It helps if you have cardiovascular disease. And that was the said benefit. And I think the publication of REWIND will bring the 75% into play, wherein you will be able to use the drug in 75% your garden variety diabetes who have diabetes with risk factors, who are at risk for cardiovascular disease, and this 25 and 75 comprising the entire gamut of patients who need treatment with GLP-1 receptor analogs. I thank you very much for your patience and hearing.